So we're still on our SCA crash course revision. Let's have a look at autism. So autism assessment, so obviously the SCA patients could come in, or mom could come in, typically telling you that she's worried about her child's behavior and that she wants to talk about it with the doctor. But she might just volunteer the information that she's worried about autism. You need to, obviously find out what has led up to that worry, what has she noticed that makes her worry. So suspected diagnosis of autism in a primary school child, if any of the following features are consistently present across different settings. Unusual characteristics of spoken language. So assessed using the child's first language if they are multilingual, for example, very limited use of speech, speaking with a monotonous tone, repetitive speech with the frequent use of length phrases or excessively discussing topics they are interested in, talking at others rather than sharing a two-way conversation, responses to others that seem rude or inappropriate, reduced or absent negative response to others, for example, reduced or absent responses to other people's facial expressions or feelings, reduced or delayed response to your name being called despite normal hearing, subtle difficulties in understanding. So if you can see here, they say despite normal hearing, because obviously if you're thinking a child is not responding very well, you need to be thinking or wondering if that child has got a trouble with their hearing. So if the parents or the school has noticed subtle difficulties in understanding other people's intentions, they may take things literally and misunderstand sarcasm or metaphors. Unusually negative response to the request of others. So essentially, this child is having troubles. If you feel the child is having troubles understanding people's emotions and responding to cues, which you expect the child of that age to be able to respond to. So certain verbal, or other sensory, like psychological, mental cues that you expect the child to respond to. If the parents or the school or any other person has noticed reduced or absent interaction with others, for example, they may have a reduced or absent awareness of personal space, or are unusually intolerant of people entering their personal space. So the child really screams and locks their door and, which, it could be. What about autism is, or autistic spectrum disorder is, you need to be able to tease out between a normal behavior in a child, because normal behavior there's a large, very wide scale, very wide margin of what is described as normal behavior in children. So the fact that a child doesn't fit into the typical behavior expected of a child doesn't automatically mean the child has autism. It's the same way with most psychiatric problems. There's a thin line between normal and abnormal, okay? Between normal and a disorder. So we need to be very careful. And that's why obviously we need to be identifying these signs that could make us worry. And then obviously as GPs will be referring for specialist autism assessments, which may lead to a diagnosis or which may lead to a non-diagnosis. So if the child doesn't have awareness of personal space, if the child has a reduced or absent social interest in other people, including peers, which again could be normal, but everyone really wants to be around people, they may reject others. And if interested in others, their approach may seem inappropriately aggressive or disruptive. If the child has reduced or absent greeting and farewell behaviors, the child has reduced or absent awareness of socially expected behavior, reduced or absent ability to share in social plays or ideas, may play alone, which again could be normal. So it doesn't automatically mean autism, but then it could mean that maybe that's a warning sign that the child could actually have autism. Reduce or absent ability to adapt their style of communication to the social situation. For example, they may be overly formal or inappropriately familiar. Reduce or absent enjoyment of situations that most children like. Now, reduce or absent eye contact, pointing, and other gestures where when interacting with others, for example, reduced and poorly integrated gestures, facial expressions, body orientation, and eye contact, reduce or absent shared attention manifested by a lack of gaze switching, the ability to follow where someone is pointing. They may look at their hand instead, or not using pointing or showing objects to share an interest. Or not using pointing. I thought they said pointing in Britain is rude. I've been harassed, personally harassed by someone before for pointing at what I wanted. And the person said it's rude. So I've heard it repeatedly in UK that pointing is rude. So I'm surprised that you know uh they expect or in Nigeria I never knew pointing. As long as you're pointing to to specify what you're talking about, I don't think it's rude, to be honest. Depends anyway. People have different cultural interpretation of stimuli actions. Now, reduce or absent ideas and imagination, for example, reduce or absent flexible imaginative play or creativity, scenes seen on visual media like TV may be enchanted. Reduce or absent, because for example, the child makes comments without awareness of social hierarchies or niceties. Unusual or restricted interest or rigid repetitive behaviors, for example, repetitive movements like hand flapping, body rocking while standing, spinning, or finger flicking, plays repetitively with objects rather than people, overly focused or unusual interest, rigid expectation that other children should adhere to rules, excessive insistence on following their own agenda, extremes of emotional reactivity that are excessive for the circumstances, strong preferences for familiar routines and things being just right. Dislike of change, which often leads to anxiety or other forms of distress, including aggression. Over or under reactions to sensory stimuli, for example, sounds, smells, tastes, and textures, may have extreme food paths. Again, if you read through most of these things, you can see that the fact the child is demonstrating some of these features doesn't automatically mean autism. And it's quite difficult because I know many of these things are quite common childhood, adolescent behaviors. It's typical for to find adolescents that behave this way actually. Teenagers who behave this way. And we usually call them, what we call teenagers to act this way. They just want to keep to themselves, they don't want to interact with anyone, they don't want to be in their personal space and things like that. So it doesn't automatically mean autism. And autism doesn't automatically mean a bad thing. That's another thing we should come to understand. It only means that the person's behavior might be different from, or is typically different from what is expected for their age. And sometimes they could have, interactions. They might have social integration problems because of the way they behave, and obviously they might have trouble integrating with society, members of society, activities, which might eventually become a problem to them and to others. Other clinical features may suggest a diagnosis of autism, or that may suggest an unusual profile of skills or deficits. For example, social or motor coordination skills may be poorly developed, while particular areas of knowledge, reading, vocabulary skills are advanced for their chronology. So they may not be so on poor in certain areas and be so good in certain areas, which is very common among human beings in general. Social and emotional development is more immature than other areas of development. Social and emotional development is more immature than area. Excessive trusting, lack of common sense, less independence than peers. So that lack of common sense is actually a common problem in society. So a lot of people may actually be autistic. in that regard anyway. Be aware that making a diagnosis of autism may be challenging, certainly in a child with a developmental age of less than 18 months, yeah? A child where there is lack of information about their early life, for example, a looked after child or an adopted child, a child with a complex mental health problem, severe sensory impairments such as hearing or vision, or a motor disorder such as cerebral palsy, a child with milder symptoms and or average or above average intelligence, so a child with maybe a learning difficulty, for instance, intellectual difficulty. It might be difficult to do a formal assessment, thorough assessment to make a diagnosis of autism. Now, how do we assess? We suspect the child could have autism. What's the assessment like? If a child or young person has a suspected diagnosis of autism, encourage and support family members and or carers to be involved in the patient's care, in the child's care and management decisions whenever appropriate. Take a history, take into account the person's communication needs, developmental stage, level of understanding, and severity and duration of features suggesting autism. Check whether they have a preferred method of communication with others, such as use of communication aids. Make adjustments to accommodate sensory impairments like vision and hearing. Use different methods and formats for communication, which are meaningful to the child or young person, such as written words, signing, visual aids, pictures, symbols, practical demonstration. Eventually, in the SCA, if your mom is worried about her child might have autism, she's concerned, you need to be finding out the impacts. Are there things, are there ways the child is struggling? Are there things that this child is struggling with? And then at the end, to your management, you need to be finding out, are there things we could do to help this child cope in this area of challenge? For instance, do we need to be involved in the school nurse, or do we need to be involved in occupational therapists, or the physiotherapist, or do we need to be in speech and language therapists if they're having troubles with their speech and language communication problems? You know what I mean? So soft plays, you know, so to find out how can we modify things to help. Give the person time to process the information before they respond. Ask the child, the young person, their family members, and or carers about the developmental history and behavior, including difficulties with speech, language, and communication, interaction with others and social skills, sensory difficulties, impact on home life, education, and social care, the severity and duration of features of autism, severity and duration of features of autism, and the extent to which features are present in different settings, such as home and school. You'll be finding out about the family history, including similar difficulties. So any family member with similar, behavioral developmental challenges or, learning problems, if they have learning or communication difficulties, similar difficulties when you're with like sort of social relationships with family members, carers, staff, like nursery staff or teachers and peers. When the child is attending nursery, what the interaction with other children in nursery, what interaction with staff there, how are things, are the staff worried, have they, highlighted any worries or concerns themselves? Any history of attachment disorder difficulties, any history of trauma, neglect, or abuse, need for support with activities of daily living. I think I've got it. Getting, of course, the antenatal and perinatal history, including maternal exposure to medications, drugs, birth weights, of course, whether the child was born premature, preterm, or term, any risk factors for development of autism. Past and present physical comorbidities, coexisting conditions like difficulties with motor and coordination skills, blood and bowel continence, feeding and nutrition, sensory problems, vision and hearing, sleeping problems, educational history of the child, intellectual ability, learning style, academic skills, any emotional or psychological mental problems we need to be checking, level of concern and impact of features of autism on a young child. So that's very important, as we said. How is it affecting this child? What's going on? Other ways this child is struggling. Could be interacting with social, with other other children at schools, interact with family members. It could be that the child, might be having some disruptive behaviors, being aggressive, having lots of tantrum moments and things like that, or having challenges with education. Level of concern and impact. So read that any previous assessments, medication interventions and response, input from professionals in health, social care and educational care settings. Now, as a GP, you need to observe the child. Usually, it's difficult as GPs. We have 10 minutes appointment, even if you do it as a double appointment, that means 20 minutes. So like speaking with the parents, obviously, it's something you're doing at the same time. You're observing the child's reaction, how the child responds to the parents, how the child responds to you as a stranger. Does the child feel relaxed and excited and happy and coming to touch your stethoscope? Is the child really interacting with you well? Those are good signs, but your child is obviously withdrawn, looking so apprehensive, which even could still be normal for children. So you're seeing a stranger for the first time, they could, they might not trust you immediately, they might withdrawn, and they might also, hide in a corner. Obviously, if it's extreme, then that becomes a clue or a cue as well that something could be wrong. The child's general appearance, developmental stage, growth, the child maintaining eye contact or the child avoiding eye contact. Again, it could be cultural, because obviously when I came from Nigeria, people see maintaining eye contact with an adult or someone that's much older than you as a sign of disrespect. Obviously in the UK, eye contact is expected when you're in a communication with someone. Now, use of vocabulary and language skills, expressive and receptive, social interaction and communication skills, behavior, physical examination, including skin for signs of neurocutaneous disorders, including skin, okay, including skin for signs of neurocutaneous disorders, neurological examination and hearing. So just looking for things like, neurofibromatosis and all those Foley spots and any other abnormal skin, reactions to various sclerosis, all those kind of things. Like we have cutaneous manifestations. Is an important thing, differential diagnosis, Rett syndrome, epileptic encephalopathy, blah, blah, blah. Anyway, let's look at management. So I think we've done the management of suspected autism. We've looked at that already. So we've done that. Okay. So essentially, it's about exploring the parents' concern. How can I help you? Could you tell me more about this? These changes or concerns you've noticed. Allow them to speak. Is there anything you're particularly concerned or worried about, and what were you hoping I would do to help today? Explore the impact, their expectations, and obviously show concern, empathy. You can see this is really, worrying to you, and it's good you've come, so we can have it. Obviously, for us to find out if what exactly is going on, and if there are things we particularly need to be doing to help, and find out impacts. Are there ways? Are there ways these behavioral changes or behavioral concerns are impacting John or Peter's or Chloe's or whoever matters life as a whole. Does she engage with other children? Does she attend nursery? Find out how are things at home. Has she got siblings? What's the interaction with her siblings like? Has a teacher, how the staff at the nursery mentioned anything to you, any concerns to you? Has any referrals been done from the nursery or from school? You need to find out if the school has already done an autism referral, but they might have done one. They need to find out if they've done one already. That might influence your management in terms of advising that, okay, maybe it's worth us waiting for the outcome of this referral. Obviously, if you haven't heard from the autism, service in the next month, if you haven't heard from them, get back to me, and then we need to chase that referral up or probably consider doing a new referral from your side as well. And obviously offerings off just to review the child again, maybe in a month's time, or in 3 months, or in a month's time or earlier if they have any concerns. And then she has mentioned some difficulties. Maybe the child is having a speech delay. You might want to be referring, obviously, to speech and language service or to the pediatrician, to children's doctor, of other assessments, or the child hearing has not been fully assessed, you might want to refer to speech and language. I might also mention that, we need to be doing a formal hearing assessment just to double check that, the child's hearing is also, normal. And in between your consultation, you always need to check what are your thoughts about everything I've said so far. Does this make sense? Like, is this a good plan? Do you see this as something that we should be doing at this point in time?